Hello everyone, my name is Shayanti with the UNM Division of Community Behavioral Health. Welcome to today's presentation for the Community and Rural Psychiatric Residency Program webinar series. A few announcements before we get started. Please make sure your sound system is muted during the presentation. If you have any question, please submit them in the chat or feel free to unmute yourself if Dr. Gomez opens the floor. For those requesting CE or Certificate of Completion, we will share an evaluation link towards the end of the presentation. To receive a certificate, you must attend the full presentation. Also, please note that you will only have 48 hours to complete the survey before it becomes inactive. Without further delay, I hand it over to Dr. Gomez, and thank you once again for joining us today.
Hello, good morning, everyone. So my name is Perla. I'm a resident physician. I'm currently doing my second year of psychiatry at UNM. And I'll talk to you about prodromal psychosis and a little bit about first episode psychosis. So I'm originally from Bogota, Colombia. I completed my med school there. I also did some general practice in a little town in Colombia, and then I did a 2-year research fellow at MGH in Boston. And then I came here to pursue my training in psychiatry. So this is the information for the credits. I don't have any financial arrangements or things to disclose. And this is also my personal presentation, and it's nothing that involves UNM. So these are the learning objectives. I'm going to talk about how to identify signs and symptoms of clinical high risk and psychosis, and to discuss the importance of early detection and intervention, and to describe the different pathways of care and the different treatment options. So in this specific topic, the population that I'm going to talk about, it's mainly people in between 12 and 35 years old that have like prodromal psychosis, or are at high risk of developing a psychotic disorder, have first episode psychosis, and chronic psychosis. It could be affective syndromes such as major depressive disorder with psychotic features, or bipolar disorder, or non-affective such as schizophrenia. The data is mainly from studies done in the northern hemisphere, and just to have into account that this specific syndrome, I'm going to talk about like psychosis as a syndrome or a spectrum, it's culturally bound. So it means that we need to correlate like the normality of based on their cultural or specific like subgroup. It cannot be according to our own beliefs. And there is a lot of research in regards insight in psychosis, also about faith and delusional thinking, and just again, to remind that that we need to handle appropriate the therapeutic alliance in people that have psychotic symptoms that are like limiting their functioning, because this will increase the likelihood of favorable outcomes. So I took this image from a webpage that is psychosisscreening.org. And this is how it looks like in the spectrum psychosis. So we have in the yellow frame, there is no psychotic disease yet, but people can have some warning signs, and this is what I'm going to talk about more. And then in the blue and red frames, you can see that it's more about how like the behavior of the disease. If we intervene early, the episodes are less severe in comparison to the standard intervention, where the episodes can be more severe and impairing and more frequent. So what is psychosis? So psychosis is a set of clinical signs and symptoms. It's also an experience. Someone can experience psychotic symptoms when they are sleep deprived, and this could be completely normal. And they could also, like people that have like chronic psychotic conditions, they can have experiences that they perceive as beautiful or enlightening, while others experience a lot of distress with their psychosis. And there must be an abnormality in between one of these domains: delusions, hallucinations, disorganized thinking, disorganized behavior, and negative symptoms. I'm not going to get too in-depth in this topic because I've seen that in other webinars. They have talked about already about psychosis, schizophrenia, first episode psychosis. So I will just focus on the attenuated symptoms. So we need to think of the symptoms as occurring on a spectrum. There are mild, moderate, and high psychotic symptoms. Mild are when you can notice that something it's like not quite as usual, but it's not bothersome. So I'm not sure why, but I don't trust my landlord. In moderate or clinical high risk, there are some symptoms that are more bothersome, and they can affect your daily life. They can affect or they can be perceived as like something is off with my mindset, like I don't know what I'm thinking about. So for example, I think that my landlord may have installed cameras in my apartment to watch me. And then there is the high or fully psychotic syndrome, that is when it significantly interferes with daily life, and the person has or is convinced that the symptoms are real. I know that my landlord is working with the FBI to gather information on me. They all want me arrested. So we can see how, like, the difference in between all of them. Okay, these are the signs of psychosis risk. So this is not yet psychosis, it's just a risk. So you can, or people can observe that the patient or their family member has a drop in grades, or they are not performing as well at work. They decline in self-care. They have new sensitivity to sight or sounds. They feel like their mind is playing a trick on them. They feel suspicious. They have strange feelings, or they don't feel at all. They have trouble concentrating. Some of them have social withdrawal, and then they can have also like hearing whispers or seeing shadows or like sounds or visual images that are not that are abstract. And this is especially significant when they have a relative with psychosis and where one of these signs is new or they are worsening and recurring, and they are starting to affect the functioning. So I have to help you share this knowledge with me, like analogy, and is imagine that the person that has psychosis, like imagine that like one of these DJs tables or where you can amplify the sounds or amplify the sensorium, the perceptions. So at some point these ones are attenuated. So some of them are high, some of them are just as at baseline. So this is how it affects them in their perceptual experiences. And then there is this mnemonic to ask and kind of remember what are the important aspects to consider when someone is having a behavioral change. Their functioning is declining. They have changes in the sleep pattern, and as I mentioned before, like this decline at work or school, and socially decline as well. The perceptual experiences are atypical, so they can see shadows, flashes, they can feel that someone is calling their name when no one is in the room, they can feel that someone is touching their shoulder or when no one is there. They can start having some cognitive problems in memory, attention, organization, and processing speed. And they understand abstract concepts. They don't understand them as well as social cues. Their thoughts is also impaired, mainly suspicious, and sometimes they can present with some delusions. It could be somatic delusions, ideas of reference. That is like when you feel that someone is giving you, like an external object is giving you a message or is relating somehow with yourself. They can be paranoid. They can have thought broadcasting, thought insertion, and grandiose delusions. And you can notice also some disorganized speech. So if you ask them something, they can jump from one topic to another topic. They can just not answer your question and answer something completely different, or they can just be like really disorganized that you cannot understand what they are saying. And yeah, that's it from here. So how can we ask about psychosis? This is different, like in when you wanna see for positive or negative symptoms in schizophrenia, that you can say, are you hearing voices that I cannot hear? You must be here more cautious, because depending on their culture, they may not disclose everything that they are thinking or feeling, but they can express some type of anxiety, and then you have to have like that ability to get in depth and try to understand where is that anxiety or distress coming from. So these are some of the questions. Are you ever confused if something you experience is real or imaginary? Have you ever felt that you are not in control of your own ideas or thoughts? Are you feeling more sensitive to sounds or hearing things that other people cannot hear? Are you feeling more sensitive to light, or do you ever see flashes, big figures, or movements out of the corner of your eye? Are you having more trouble understanding what people are saying or getting your point across? And if they answer yes to any of these questions, then you need to try to explore what is going on and see how distressful this is for them. And these are more questions about psychosis. The ones prior were more about psychosis risk. And these are other type of questions that you can ask just to understand what are they experiencing and how is all this impacting them. And if this is taking like a more episodic or recurrent or progressing nature. Yeah. So you can ask them like, tell me more about that experience. What do you make of that? Why do you think this is happening? How so? Or to see how this is impacting them. You can ask those questions that are there. So there are also some more qualitative and quantitative like questionnaires that you can ask, but I have to point here that it's important that you if they answer yes to some of these questions, that you kind of try to understand what is going on, because some of these may be normal experiences, and yeah, so it could give you like a false impression of someone that is having like clinical high risk just by doing the questionnaire. So you want to get into them and like really try to understand how much this is distressing them, and yeah, what is their understanding of those experiences. So in like 1990, they decided to include like diagnosis criteria for clinical high risk for psychosis. Before that, there was just like schizophrenia, and they were not paying attention to anything else. And the idea of this was like to start anticipating like possible negative outcomes of also like some efforts to prevent the transitioning to a psychotic disorder. So we can see in the DSM-5, the attenuated psychotic syndrome. It is like it is part of the other psychotic syndromes, and then yeah, I forgot that word, but it's there. And then there is also like the brief limited intermittent psychosis. So it's when people experience psychotic episodes for less than 1 week, and they resolve without treatment within the previous 12 months. The attenuated psychotic syndrome is within the previous 12 months. Also, they have to experience like not like under threshold psychotic symptoms. And then the people that have first degree relatives with schizophrenia or bipolar or any psychotic condition, and they have a psychosocial decline, you have to consider them also at very high risk for psychosis. And so this is like the way we need to think about how to intervene depending on the severity of the symptoms. So if the patients are not having psychotic like symptoms, or the symptoms that they have could be explained by their cultural background. For example, someone from Mexico or any like culture that has belief systems that they can communicate with the ancestors or with the dead people. If this is something that is like normal in their culture, we cannot consider this a psychotic symptom. This is something that is like part of their cultural and family beliefs. So we can just reassure and just redirect and give them like warning signs of what they need to watch out in case that they start having psychotic symptoms. If they are having mild psychotic symptoms but this is not like impacting their life, so you can just monitor them regularly. You can try to see if you want to see them every year and let them know if things change, that they can reach out to you earlier, and give them like resources of what they need to look like, all these warning signs, so they can go and look for help on time. And there is like this more specialized assessment and treatments that I'm going to talk about in a little while, but this is for more like for first episode psychosis. So there's like these services and like specific care. In 1980s, like most of the psychotic crises could be managed or treated at home. So then they started to create like these community-based teams where they could support patients and families with that were going through psychotic experiences. By then, these services were split into the first episode psychosis versus chronic psychotic symptoms. So we know that, like in the same type of a spectrum, the people that are clinical high risk, about 20% of them can, or 22% of them can decline and develop like a first episode psychosis. And also for those that have a first episode psychosis, they I don't remember the number right now, but some of them is not very high. They can have like they can develop in the next 2 years a chronic psychotic syndrome, or they can just recover. So in the web page that I told you, you can see the different pathways depending on the state, like the phase that the patient is, and how impairing their symptoms are for them. So in other webinars, I know that they mentioned Connect, but I just want to highlight that this was the clinic for high risk psychosis, and now is not it's not working anymore, and now it's just like early and cope. So you can always like reach out to early and cope if you have any patients that you are concerned about psychosis. And I think that was all that I wanted to share. I don't know if you have questions. Oh, sorry.
Thank you for the presentation. If somebody have any questions. I think there is a question in the chat. Dr. Gomez, can you look at the chat?
Yeah, I can see that. Like, I'm not sure yet. I know that they are planning to do a transitional age clinic, and this could be one option, but I would say, no, I don't know. I would say just try to reach out to, I don't know, too early and see what they can recommend. Maybe Dawn can, I saw her, Dawn can say something. But I know that these are like this patient population is still weird. Like unfortunately, there are no, like not an organized clinic with them now.
Yeah, I can jump in there, Dr. Romero. Dr. Alonso Marsden, you can just reach out to me directly. So we're able to do the SIPs, the structured interview for psychotic risk syndromes. They're also, yeah, as Dr. Romero said, there will be a transition age youth clinic. So they will specialize a little bit in that. But if there are questions regarding psychosis in general, you can reach out directly to early. There's also an ad hoc form that's an early psychosis referral. You could also fill that out. That comes directly to me and a couple of other folks on our team with regard to what you might be looking for, whether it's just an assessment or you're looking to refer and that kind of stuff. But if there's any questions, I'm easy to reach on Tiger Connect or email or in a patient chart. You can just email me there, and Bess Friedman is probably the best way.
I think there is another question from another person.
I didn't receive the question. Can you read it to me, please?
If there is no question anymore, we can end the presentation. And thank you everybody for participating us. And thank you very much, Dr. Gomez, for giving your wonderful presentation.
Okay, thank you so much. Thank you.